Hello, everyone, and welcome to the November edition of our Q&A. Thank you so much for being patient as we got a few minutes late start with some other obligations just before this, but I'm going to tell you that Cindy and I are warmed up and in full throat today. Cindy, how are you? How are you doing?
I'm doing good. It was quite the invigorating conversation we're just coming off of about the final rule. So we've been getting some questions about that, and I'm sure that you've been getting them as they come into us. So I imagine that some of those topics, very same topics, are going to come up here now.
Awesome. Okay, so I'm going to just start off with a really good question that was submitted to us prior to this session, and at discharge, can a patient be marked not homebound? The person heard that this flags the episode and could affect reimbursement. Is that true?
You know, that has been a long-standing myth in home health because of this idea that, yes, homeboundedness is a qualifying criteria and folks need to be homebound in order to receive services in their home. Obvious. Well, how does that then carry over to the discharge? Um, if the patient truly is no longer homebound, that's probably part of the reason we're discharging. They may still have some struggles, and for some patients, getting out may still be an issue, and but they just don't require our care anymore. But this idea that someone has to be homebound all the way to that final visit, it is not true. That when we look at this and say on the final visit, if this person is truly no longer homebound, then that speaks to why I'm discharging. So the idea that if I, put down not homebound, I'm going to get, in trouble and they're not going to pay me. Very often when it's these isolated things, such as I said they weren't homebound or they walked more than 150 feet. So that must be the reason that I got flagged and I got denied. Those kinds of things may get you flagged, but they're not in and of themselves going to get you denied. They have to look at the full amount of documentation related to that patient encounter. So I wouldn't panic that, if I said you weren't homebound on the final visit, that's a straight path to denial. I would want to make sure that my final visit does speak to why this additional visit happened, what was the point of wrapping this care plan up, and that I can even pull it in and say that's part of the reason why we're discharging. They're in fact no longer homebound.
And Cindy, that makes complete sense to me, and I wanted to make sure that everybody had the opportunity that if you have any additional questions, to use our Q&A box to submit those questions, and we'll get to as many of those as we possibly can. Um, Cindy, on another note, with the PHE, I'm hitting you with some softballs out the gate. With the public health emergency extended into January 22, Oasis E is going to be 2024, correct?
No, that is not correct. And I just want to use this as a way to remind folks that you are participating in a Q&A, not a formal presentation. And so we don't have slides and the traditional things for those of you who may not have participated in one of these before. But we are a little bit more candid because it's not necessarily a formal presentation. So if you hear some frustration in my voice because Sherry basically poked the bear with that question, it's because I'm disturbed, honestly, at the number of agencies that didn't get it in the final rule. It was very clear in the final rule that Oasis E is happening January 1, 2023. Now, I understand some of the confusion because Oasis E was supposed to happen well before now. And they delayed it by tying it to the public health emergency on the idea that Oasis E would not begin until one full calendar year past the end of the public health emergency. I believe when they put it that way, like many of us, nobody anticipated necessarily how long this PHE would continue. So when the PHE was extended into January 2022, the logical thought was there. Now that means we can't touch E until 2024. Seeing the writing on the wall with the continued extensions of the PHE, CMS in the proposed rule put that they wanted to disconnect Oasis E implementation from the PHE. And that is exactly what happened in the final rule, that this is not going to be connected anymore, that however many extensions there are will have nothing to do with it. Oasis E implementation is January 1, 2023. And I'm concerned, Sherry, that it's also kind of buried in all the other conversation. I see some of the blasts going out with the summary of the final rule. And I don't see anybody putting in their summary, Oasis E, January 1, 2023. There's value-based purchasing, there's supervision of the aid, there's what happened with OT. And it's like, and it's not there. And so I think that's fueling this idea that, oh, that's further down the road. It actually is not. So 2022 is going to be yet another fun and frolic prep year of dealing with, and we know, those of us who've been around a while, anytime Oasis changes letters, there's substantive change. It's not
Mhm.
just, a couple Q&A updates and some tweaking. It's going to be a substantive change. And we haven't had a substantive change to that tool in quite a while.
And Cindy, I'm just going to just piggyback on the Oasis conversation. There were a new set of Q&As that were put out in October for the Oasis. They come out quarterly, guys, and you should really set an alert to yourself to remind you to go and look at these. This particular one had an immediate impact on an item. So the question came from a provider in Hawaii. Hey, I'm just putting it out there. If you need us to come to Hawaii to your agency, let us know. We will come see you in Hawaii anytime, any day. Okay, so we now need to capture, quote, deaths in the ED during outpatient surgery, etc., unquote, as a death at home, RFA 8. Made me wonder, how does this affect our agency? Is it a publicly reported metric? What are your thoughts?
Well, what happened, and it's very interesting from the Q&As. You can see that because of the delay in E, it's like the Q&A, quarterly Q&A still happened, but they kept getting shrunk, as it were. It kept getting smaller and smaller because there weren't really substantive changes, so there were fewer questions. This one kind of came out from, I think, a very astute individual that was looking ahead at some of those measures related to the flow of health-related information, and that the expectation is when we have a patient go to another setting, then this is the information, particularly a med list, that we are supposed to be sending along with them as part of a care transition. Somebody looking at this said, wait a minute, the way we use time points, and there's always kind of been that conversation about, okay, if they die in the ambulance en route, we use death at home. If, they haven't been admitted, all of those things. But somebody realized that the current guidance would have put us in a position where someone goes to the hospital and dies, I'm still obligated to send things like the medication list to the hospital. And the question was basically, I don't think that makes sense, dear CMS, that I'm going to be to deal with one of your measures, I would be sending information to the next care setting on dead people. And
Mm-hmm.
so this doesn't seem to make sense. So CMS just went, whoa, okay, they didn't say this, but you could tell it was hadn't really thought about how those two things coexist, and said, okay, immediately we're going to change how you utilize that time point. So does it affect me as an agency that, it changes my care delivery or no, but it's a positive thing to say in those situations where a patient passes away, yes, by indicating and utilizing a death at home designation, then I am not going to be held in the other situation to a standard of sending information along to the next facility. So I encourage folks to look at that Q&A because it's very specific about what they want you to do with it. But as I alerted you, Sherry, I can count on one hand anytime I've seen a Q&A that contained the words effective immediately on
Yeah,
something like that. That
that
jumped
definitely
out.
caught my eye. That definitely
Yeah.
caught my eye when I saw that.
But I
Notice
think
that
it
the
also before we
go
switch though,
ahead.
Sherry, I think it's again, it speaks to why things like submitting questions to the Q&A, participating in open comment periods, when we do that thoughtfully, when we have a real thing we figured out that doesn't really make sense, can be extremely beneficial to say, oh, they hadn't thought about that, now they can fix it. Or with the proposed rule, you can do one, telecommunication aid supervisory visit per year. Yeah, what use is that? Oh, wait, maybe we need to fix that. So I think it just is another great example of how that process can be very beneficial to the industry. It also, though, has the downside of a lot of people don't pay attention to the Q&As. And once they're out, CMS believes they've done their piece of it's there for you. We have to make sure we stay on top of pulling those up and checking for anything new or important like that that we do need to implement.
Okay. Now from an Ohio provider, we have a home health OTR ask a question about adding and referring other disciplines. She said there might be something in the Ohio State Practice Act, but I'm not finding it. Can PT and OT or speech refer other disciplines? For example, if we receive a referral that has OT eval and treat while the OT is completing their evaluation, can they then order PT and speech if they see a need?
Well, I think we have to be very clear because some of the wording on that can be a little confusing. If
Mm-hmm.
I go out as a PT and do an evaluation and I see a need for OT, I cannot just write an order and say, you get to have OT because I said so. I can reach out to the physician and say, I'm seeing a need for OT. I would like to have OT included in the care plan. The doctor's the one who's technically ordering it. I
Yeah.
am not unilaterally ordering it. And I find that question kind of a little of a head scratcher in a way because it's like, nursing's been getting therapy into plans for years and
Right.
nobody ever said, is nursing ordering therapy? No, nursing reaches out to the physician and gets a physician order for therapy. It would be no different for an OT, a PT, or a speech language pathologist to do that for any other discipline. Or if I'm out there as the OT and I think there's a need for an aide, I can reach out to the physician and see about getting an aide added to the care plan. So I have to have that physician loop piece because we'd never say, I can order it. I can go through the process other disciplines do of collaborating with the physician, but ultimately they're the ones that are ordering that care.
And this is a perfect example of where a well-written, good written, who am I? A well-written verbal order is in place that you can access and maybe have a template for in your agency that you call the doctor's office, get the verbal order, write it up accordingly, and then your agency can decide whether or not that's added to the plan of care depending on when it comes and what time frame your policy says. So definitely, if you see a need that a patient has, you can definitely get involved in ordering that, and that is a COP issue probably and a survey set issue and not necessarily a practice act. However, I am going to caution you on the reverse. Cindy, we hear this all the time. The therapist, the PT goes out to do the evaluation and then they say they don't need OT even though OT is ordered. I would caution very strongly that you do not do that because then you are deciding whether or not another skilled intervention is appropriate and you do not own that skilled intervention. Do you want to elaborate a little on that a little bit?
Yeah, because I think very often, let's just be honest, the times we see where PT and OT is ordered, or even speech is ordered, and PT is getting rid of the orders for the other discipline, saying that it's either, it's not necessary or whatever, or we see the PT order including the language to assess need for OT. Again, I want to reiterate, we are three separate skilled disciplines. And the only time we ever see agencies using those phrases with any regularity is really about a shortage of OT or a
Mm-hmm.
limited amount of speech. It's
Mm-hmm.
not really clinical. It's really trying to figure out how to potentially work around the physician order. So I think in reality, if I only have very little or potentially none of this service, it feels like, well, this is a way to manage that. We'll defer to PT about who can get which one because we have more PT than we have the other two. But two things. One, if you suddenly got more staff, would you continue to have PT assess the need for OT? Most likely no. And the issue it remains that if looking at the conditions of participation as a whole, if I've gone out and this patient does in fact need a discipline or a service or an approach to care like maintenance therapy that my organization does not have or does not provide, then I am obligated to inform the patient and provide them with alternative agencies to provide that level of care they're looking for. So if it that's where it gets very concerning to me, Sherry, because it's not a consistent application of you need or don't need OT is determined by PT. It is very much staffing related. The reality is if they need it and you don't have it, we need to offer them an alternative option, not have PT be the screener and then, oh, OT shows up, so now PT doesn't do that anymore. It's just the strategy is concerning, and it really is kind of stepping over some boundaries in terms of the physician. Now, one thing before we move past this, Sherry, because this is I'm telepathic today. I know at least one person is thinking this, but I have physicians who order PT and OT together all the time. It doesn't necessarily seem to be that they think they need them. It's just their order is always SNPT OT, SNPT OT. And I'm strapped on the OT side, and it seems like there's a whole lot of this, and is it really necessary? I think working with our physicians about orders is an important piece, but I would still stand behind the individual disciplines should be doing the assessment to determine what is really appropriate for this patient and not having others do it for them in those situations. So I know that was a little long-winded, but I think it's been an issue where it is more about staffing than anything else. And there are risks you're taking with this hit and miss, we do it, we don't do it kind of way that's been applied in many home health agencies.
And I would argue, and not to make this even more confusing, but I would argue that you get yourself prepared by having some contracts out there for community-based or outpatient-based therapists that can do PRN visits for your agency. That is an allowable thing, and there are resources beyond just your agency walls that you could access to have orders answered and keep those patients in house. You just have to be prepared that that's coming your way. If it's not there yet, it is coming your way, where you're asked to do things like dietary or psych nursing or OT or speech, things that you don't typically do every day. And you can set up those contracts ahead of time and take care of that. So I just
One
really, really encourage them.
One other element, Sherry, is I think particularly around OT and speech, like you said, not necessarily used as heavily as PT. This kind of rationing also affects an organization's ability to figure out what an appropriate staffing model is.
Mm-hmm.
And so I guess I'm having a little bit of PTSD from my days as a rehab director, having these ridiculous back and forth conversations about, I need another full-time OT. No, you don't. The volume we have here is for part-time. No, the volume there is being chronically rationed. If you give me another one, we would be in a better position to do this. So
Right.
you have to produce the data of, one person is working themselves to death to 2 FTE equivalents before you'll let me post a position for another OT. Well, then this first one burns out, runs away. Now I've got nothing. I think that's also where operationally we see this rationing become, I've been known to say, Sherry, where it gets concerning to me is when chronic triage becomes best practice. We've
Right.
learned to live without speech. We don't need speech. What do you mean you don't need it? Well, we always have this 2-day a week person, and that's all our agencies ever needed. Are you sure? Or is that just what was available and what everybody got used to doing as opposed to what they needed? So I think there's other aftershocks of rationing that we have to consider, that even if we have to deal with a rationing situation for a period of time, what are we really envisioning is the amount of help? And is it making sure we have some contracts in our back pocket, or we know where to go when it swings the upward direction so that we're prepared for it?
Okay, and we're addicted. We're absolutely 100% addicted to this idea of value and productivity being based on visits. And so I could wax on for a long time about what we consider productive and what we consider valuable. And we need to be readdressing that as we go into some of the new legislation around home health value-based purchasing. That's later, but I have another great question. When
Oh,
can
wait, no, I
Go
got to
ahead.
do a plug here, Sherry. I do. Because if
Okay.
anyone was really interested by that and said, I wonder what Sherry does think about that. We do this routine Q&A webinar, but we also, if you aren't familiar, do what we call unfiltered productions, which are free podcasts on our YouTube channel, where you do hear a little bit more edgy, a little bit more opinion on some issues related to home care. We're not trying to be, mean spirited or ugly or anything, but some of these things we need to have a little bit more candid conversation about, at least to provoke thought and discussion. So I know, Sherry, we've got one, well, probably more than one now that touches on the visits issue. So if you could just tell them how to get to our YouTube channel, I think that there's some thought-provoking things around that visit idea, both now and in ones we do in the future.
Well, my recommendation is if you're familiar with YouTube, go to YouTube and search Kornetti and Krafft, and it'll take you to our page, and you can subscribe and get all the free info that we post on there. Cindy and I started podcasting, and Cindy D and I started podcasting because it was cheaper than therapy. Right, Cindy? Sometimes you can only recommend and suggest things by screaming into the abyss so much that you want to pull your hair out. So we decided to podcast and let you guys in on how frustrating some things can get and how things hit our radar. So next question, and please, if you have a question, enter it into the Q&A box, or if it comes up after the session, feel free to contact us via email, and we will answer it forthwith. Okay, next question. When completing competencies, does it have to be the same discipline completing competency checklists, or can a director of rehab complete competencies for multiple disciplines if they are deemed competent ahead of time?
Well, Sherry, I'm going to turf that back to you as a former agency owner. I mean, what are your thoughts on that?
I think there's a certain level of insanity when it comes to competencies, because if you went by the theory that the person who is in that discipline has to do it, then who's competencing that person? And then later on, who's competencing the person who competencies the person? So you could get into a kind of a cycle of redundancy. I think that ultimately, whoever is the highest skilled person in your agency, and by Medicare standards, that's the DON. The director of nursing is considered the grand poobah over everything in the agency. If they deem your director of rehab or your director of clinical services or your LPN as proficient in something, they can then be a competency provider for that thing. For example, in our agency, this is just a random anecdotal statement. We had an LPN who was Red Cross certified, Red Cross instructor, Red Cross everything on the AICD device. Knew it better than a lot of people who are using it in the hospital. The automatic defibrillator, for everybody who doesn't know what the AIC device is. And literally, they could write a book on how to use that thing, but there was an argument about whether or not they could competency other staff members. I argue that that resume item and what they had as a competency and a certification outside of the agency superseded any discipline issues as far as an LPN competency and RN on the AICD device. So it's really important that you know the background of your clinicians, you know what extra education that they've had in the past, and you can speak to that eloquently either in writing or in the presence of a surveyor of why that person was the best person to competency on that particular skill.
I think, Sherry, I agree. My only clarifier that I always did from a rehab director standpoint was if we were really talking about competencying very clinically driven specific things like completion of a bedside swallow assessment from speech, I didn't feel that I was remotely qualified to do that. And we would, at that time, we were part of a hospital system, borrow other speech paths to be able to sign off on some of those very specific things. But I agree. I mean, a lot of those things, want to make sure you have your policy procedure and who's been okay to do that. But to me, on some of those very specific things, like Sharp's debridement, if PT was going to be involved with that, to make sure we had the right people on that kind of stuff.
Well,
Make
and
sure
Cindy,
everything's good.
I just remembered KCI, the wound vac.
Hmm.
I'm sure that, and this is me being sarcastic, so please forgive me, a little bit of the unfiltered is sneaking in here, Cindy. I'm sure that it is an RN that comes to your agency to teach you the wound vac every time, right?
Hmm.
That's sarcasm. That was big sarcasm. It is not. It is somebody who has extensive knowledge and
Right.
skills with that wound vac device. So it's more important. The discipline is not nearly as important as the skills and how they acquired them and how they've kept them up. So that's probably as concise as I can be on that question. Okay, we have another question. Woohoo! Okay, notice of admission. Yay! Said nobody in home health ever. Okay. Is it coming? Well, first of all, is it coming January 1st, 2022? Has it already started? And does it replace the no pay wrap?
Okay, it has not already started.
Okay.
Um, it's my understanding. And yeah, I know you were on a different webinar yesterday. Jump in if you have thoughts specifically on anything related to the NOA. It will be replacing the no pay wrap. The no pay wrap was really never a permanent solution. It was really intended to be a transition off of the pay wrap. And some of us may say, well, that was kind of, couldn't we just gone straight to the notice of admission? Yeah, maybe. But this was seen as kind of softening the transition from needing to submit information that was directly related to payment to now we're submitting information strictly to essentially placehold this individual as a home health patient in the Medicare system. Because we know that once they're a home health patient, they are blocked out from having other services such as outpatient therapy and those kinds of things be able to bill concurrently. So the notice of admission, and there are many webinars available out in the industry about this. This is not what I would call our sweet spot in terms of a deep dive on the NOA. But yes, it is going to be moving forward. That did not get swept up with other things in the public health emergency. So it's going to follow the same original transitional plan it had from WRAP to no pay WRAP to NOA.
And
January.
I want to caution agencies that it does not take the place of you going in and checking the common working file and
Mhm.
ensuring that the patient is not being seen either A, by a skilled nursing facility or inpatient rehab facility and or another home health. So it doesn't decrease the burden of the home health agency at all as far to prove that. It was just a really successful effort by outpatient providers to ensure that they had noticed that a person was in home health or in a home health episode before they attempted to bill, because really clearly they cannot, an outpatient rehab facility or an outpatient provider cannot bill Medicare Part B if a patient is currently on Part A services. So their claims would be denied in that situation. So instead of and we could argue this till the cows come home, Cindy, but instead of requiring them to become fluent on the common working file, they created another requirement for home health. And that's just, it is what it is. It's kind of like the face to face. It's not going to change. It's going to be a requirement going forward. And it's part of the COP changes and part of the final rules. And if you have problems with it, I encourage you to really comment on these comment periods when they come out, when new rules come into place, because this truly was a great effort by outpatient providers and getting this document into our normal regulations now. Cindy, did you have any other comments on that before I go to the next one?
Well, is your next one also about outpatient therapy, or is
I,
this a segue I can jump on?
you jump on that segue because I saw that question and I figured maybe you would grab it.
Yeah, I'm looking at it because it does fit here in terms of the mentioning of outpatient therapy. Um, can a patient, a home health patient, go to outpatient therapy? This question has kind of reared its head again. And what's interesting to me is the wide variation in responses I see others make to this. Very often it is a very resounding, absolutely not. I mean, this makes no sense. If you are receiving home health, why would you be going to outpatient therapy? All right, what we have to step back is look at our rules. And our rules basically say that the 6 services that we provide in home health, if a patient is receiving home health, those 6, nursing, PT, OT, speech, medical social worker, aid included, but that in there is part of consolidated billing. So if the patient is receiving those services from a home health agency, that is who's responsible for paying for those services. So you'd say, well, that makes sense. I have a nurse, they need a nurse, I sent the nurse, I pay for the nurse. Yes. But there was an acknowledgement in consolidated billing that there may be situations in which what the patient needs cannot be brought to the home, that the patient could go to an outpatient service to get that. Um, the example very often tends to be parallel bars. Early on, that was a big discussion point, that if I had a patient that they needed parallel bars, clearly I don't have those that I can drag to the house. So I'm going to have them go to outpatient to work on gait training because of the parallel bars issues. Well, there's a multifaceted thing that comes into play. Because it's therapy, that outpatient provider cannot bill Medicare for those treatment visits. They'll get kicked out. Thus, the whole common working file issue. They cannot bill because therapy is part of home health services. So, what would have to happen is if I'm sending them to outpatient therapy for this, from the billing side, I would need to have a relationship, a formal relationship between myself as the home health agency and that outpatient provider that outlines what this is going to cost, what I'm going to pay, what those parameters are, and negotiate all that in advance so that I know I am sending them to outpatients for this specific issue. This is what I'm going to get billed by the outpatient provider, and I have to pay that as the home health agency out of what I get paid from Medicare. Also, I have every right as the person who's paying it to set expectations about things like I want a copy of documentation. That documentation needs to be accessible in the home health record because I am paying for this service and the person is still a home health patient. Those are the billing documentation logistics.
Mhm.
The thing we have to think about is if somebody can go to outpatient to do therapy, are they still homebound? We know that patients can go to dialysis multiple times a week and still be considered homebound, but we still have to address that. That maybe that is all that they go out. They come back from dialysis. We can't even see them the same day because they're so wiped out. It is very difficult for them to get there because even though dialysis is considered okay, potentially under homebound, if that person is, jumping in the car to be driven over to dialysis, finishes that up, can stop at the store on the way back, or feels real good and is, messing around in the yard that afternoon, yeah, we would question homeboundedness. So there isn't a just because dialysis is okay, well, then I can send you to outpatient therapy and it be okay. I have to be very clear exactly why I chose an outpatient venue for this and speak to homeboundedness. So also the reason I have to have a relationship with outpatient is if we don't have one, then I am not obligated by rules to pay them for those services. If I did not
Mhm.
know they were going to go to outpatient therapy, if we do not have an agreement, then I am under no obligation to pay them when they don't get paid by Medicare. Back to what you said earlier, Sherry, this is what was a primary driver of keeping this notice of admission thing in play was because outpatient providers, home care was done, send them on their merry way to outpatient. They wouldn't check, they didn't know, they didn't check with the Medicare patients, and they kept running into billing issues. So this is supposed to help alleviate some of that on their end. Doesn't really, do a whole lot of good on ours. So technically, yes, you could send somebody to outpatient therapy and they'll still be a home health patient, but there's logistics that have to be managed. There's homebound that needs to be managed. And somebody's probably going, Sherry, that was a lot of talking about parallel bars that I don't think this ever happens to me. This wouldn't apply to me. But there's always one that sneaks in, and that is a modified barium swallow assessment.
Are you
So
reading my mind? Are you reading
if
my mind?
that's the one, because everybody, the example tends to be in the manual about parallel bars, and I always kind of go, really, that's going to be a one in a zillion shot. Where we always ran into it was with respect to the modified barium swallow,
Mhm.
because yes, you're sending them in. The speech pathologist says they need to get one. The doctor says great and orders one. Off the patient goes to the hospital to get it. Well, we can't bring that kind of equipment to the house. It's ridiculous. I know. The equipment cost, the technology cost, we're not charged for that. We are responsible for the speech pathologist's time involved with doing that assessment. And that's one that tends to slip through the cracks because when the hospital tries to bill for this, that speech portion is going to get kicked out because they're a home health patient. And once again, if I don't have a relationship, a formal relationship with that entity, I'm not forced to pay them, but I probably want to look at my referral stream and decide whether or not this is a hill I want to die on, with respect to refusing to pay this particular situation. So what I tend to see is if this has happened, yes, we should have known. They probably didn't know. Here's a teachable moment, and here is an agreement going forward, because I am not going to pay full rack rates for this because you don't even get paid that. You bill that, but then you get the reduced rate from Medicare when they pay for this speech element. Doesn't mean I'm now going to pay your full list price when I'm paying you out of my Medicare money. So those are things we need to consider, especially if we have a good amount of speech therapy going on. And again, it might seem like, well, it doesn't happen very often, so I'll just deal with it when it happens. Yes. But back to the original question, Sherry, I get overwhelmed that so many people just flat out say no. Nope.
Hmm.
You cannot go to outpatient therapy and be getting home health. You can, but it needs to be very specific. It needs to be very intentional, and you've got to have all your ducks in a row. But always keep in mind, if something fell through the cracks, and I used to see it, Cherry, with wound care, that we had a patient in home health. They went to the. This is before the wake up call about whirlpools. You know, when Medicare said we're not
Hmm.
paying outpatient for whirlpools, so suddenly they all had a fire sale and got rid of the tanks. Before that, it would be a home health patient went to the doctor. The doctor looked at the wound and said, "Oh my gosh, you need whirlpool." Would set up an appointment the following day for therapy. We didn't know anything about it at all.
Hmm.
And then by the time the nurse went back, they'd gone 2 more times. So now we had 3 trips for this whirlpool, and we did not know about it. That was much more frequent and much more unpleasant, with outpatient providers, getting all mean and nasty with me, demanding that I had to pay them because Medicare says we have to pay for this. And it's like, you didn't read the fine print.
And the same thing is true for hyperbaric chambers,
Mhm.
and it has to do with the discipline that's providing that care, guys. If you're a Part A provider, if they go to the hospital for the modified barium swallow, the Part A time, the hospital time, is paid for. It is not part of that consolidated billing. It's the Part B charges of the speech therapist that get involved, or this Part B charges of the OT or the PT. Physicians, it's a little bit hairier with physicians, but oftentimes they're bundled into the Part A charge, and we never see those bills. We see them for the ancillary services for the disciplines that can bill for their services, and it's not the individual doing it; it is the billing department at that level of care. And it's just it is possible, but there needs to be some work done ahead of time. And just be aware, if your wound care center has a physical therapist as one of their clinicians, that you might see one of these communications about billing for their services. The next question, Cindy, and I'm gonna poke the bear again. Uh,
Oh
I like
boy.
doing that to you. I like doing that to you. Um, are there issues with pulling back an OASIS that you have already submitted to the state in order to make corrections?
Boy, you pick multifaceted questions. I think people go, can't you just say yes or no? And that's the answer to the question. We know that the process of submitting an OASIS does allow us, if we realize that there are things that need to be corrected, we can take that back and make corrections. Ultimately, CMS has been clear that what they want is good data. They want reliable data. And when we submit an OASIS, they are functioning on the assumption that by the time it got to them, this thing is in perfect form. It's coded the way it should have been. The OASIS responses are all intact and defensible. Fabulous. That's their standard when they get it. So when we realize, oh my gosh, we forgot something significant, or no, we really need to fix this part and there's a real reason to do so, we have that ability. Early on, people kind of panicked because they're like, doesn't that look bad? I mean, doesn't CMS, if I take one back, I'm suddenly on yet another naughty list and they're going to come get me. Well, CMS tried to assure people that that was not the case, although there was a period of time where they were talking about, that state surveyors were tracking how often we did it, and they were going to be the ones to kind of investigate further, and nobody wants to annoy or attract the attention of a state surveyor. So then it became, I don't do this ever, or rarely ever, ever, ever. I'm not suggesting that we do it with reckless abandon. What I'm saying is, if we genuinely come to realize that there are errors on this, significant ones, we can do this. What I don't want to encourage now is, because what we're starting to see for some agencies is that this We went from I won't do it because I don't want to end up on a bad list with a surveyor to I do it all the time. I do it all the time. It just goes in and then, oh, wait, my reviewer got a hold of it. So we pull it back. And then, we just, in order to expedite, getting things through, the clinician, it goes straight from the clinician into to Medicare. And then we take it back and then we fix certain things. I would be cautious about that. I would say if it is an excessive amount of time that we're taking it back, that this could attract some attention as to trying to figure out why you're doing it, especially if it's it's happening consistently and more often than not, what you're resubmitting is a higher level of payment.
Hmm.
Again, it could be absolutely legitimate reasons for that, but you can see where from CMS's side, I'm assuming when you give this to me, it's good to go. You're taking it back on the regular and you're giving it back to me at a higher reimbursement rate. So is this really about errors or are you trying to get more revenue out of this case? And I'm not saying that an individual agency that does that, that's the motivation, but because of the behavior of a few, CMS typically, I would say we're very often guilty before proven innocent when it comes to certain things, like how come your outcomes look like that? Because certain questions, once we put them in a value-based situation or a star situation, suddenly the patients all get worse. The functional scores for PDGM were expected to fall a third, a third, a third between low, medium, and high. And then early 2020 data, it's skewed higher to the high than they thought. Oh, happens to be where you get paid more. So there is now this chronic suspicion about why we do what we do, which is why I would be cautious at how regular I do it, but not phobic to the point where I never do it. Even if I figured out, oh my gosh, we got this document in, there's 5 more diagnoses on it that we didn't have at the very beginning. These are actually relevant to the plan of care. I need to fix the coding. You can do that. You just want to make sure you have very clear parameters about that decision and keep an eye on how often is that actually happening.
That's excellent. And I want to remind everyone that we have an information slide that we will be providing. And that information slide will have our email addresses. And if you have any questions, it also has our website address. If you have any questions that come up after this session or after you listen to the recording, please contact us and let us know if it's a question that you need answered immediately or if it's one that we can include on our January session of the Q&A. We plan on going forward and providing these every other month until probably mid next year, where we will likely go to monthly. This I'm kind of springing this on Cindy because of the implementation of Oasis E and all the questions that are going to be surrounding that. I have a coding question, which is for me. I'll ask myself the question.
I'm going to say,
For
please don't ask me the question.
the question is, can a clinician, and I say I have a question and then I went away from it, so it's not there. There it is. For a diagnosis to be resolved, does it need to be confirmed by the MD or can a clinician do it? A specific example is a jaw abscess. Hospital DC summary states draining purulent fluid. However, start of care clinician documented resolved. Okay, I'm going to tell you, for a diagnosis to be resolved, it has to be physician documented. Just because it was draining purulent fluid, that did not classify it as an abscess. As we know, clinicians out there, nurses that might be on this call, therapists that do wound care on this call, you can have an abscess that's not draining. That can absolutely be something that's ongoing that you would not be aware of. So once again, with any coding issue with these kinds of situations, we rely on the physician to sign off on and indicate and communicate that conditions are resolved. If I was coding this chart and I saw a disconnect between the narrative and the narrative note that the clinician put and the diagnosis, I would leave a note to have the clinician or the case manager contact the physician's office to get verification of the resolving of that issue. And that goes for any diagnosis, but this is particularly a wound diagnosis or those kinds of things. There can be a lot of communication back and forth based on how they show up when you see them in home health. So you cannot assume that it's resolved or make that clinical decision unless you are a physician, an ARMP, or a PA. In some states, not even the ARMP and PA. That's a whole other conversation. Um, Next question, Cindy, you ready? Because
Hmm.
we got about 10 minutes to go, guys. We're going to shove as many questions as we possibly can in here. Um, how often should I be auditing my internal reviewers? I can't believe this was asked because we've been blasting a lot about this. Do they need regular education, or is that up to them to get it?
Well, you know I love that question because especially with Oasis E now officially coming, it's always kind of concerned me that the reviewer and the proficiency of the reviewer somehow gets lost in the shuffle. I think it's from a variety of things. We know first and foremost, if we want accurate OASIS, we need to make sure that the data collectors have the information that they need. Because ideally, we want them to fill it out and get it right the first time so that this just continues and smoothly moves through the process. But we know that we have some issues and concerns, and we want to make sure that they really do understand. So we've created that level of review to check that work. Now, some of you have probably heard Sherry and I talk about we're not a big fan of checkers, checking checkers, checking checkers, but to never check your checker is concerning. And I think sometimes it's, well, they have a credential. They got a credential in coding or they got a credential in Oasis, so therefore they're good. Um, we do outsource coding and Oasis review here at Kornetti and Krafft, so we have reviewers. We audit them at least 3 times a year because just because you have a credential doesn't necessarily mean you are consistent in the actual work product, that you're applying what you learned to get that credential consistently and reliably in real chart situations. So a couple quick examples. We've had folks that are clearly certified coders. They pass the test. But when it comes to looking in the chart, knowing how to sequence, being able to determine what actually is the focus of care and how this aligns with the face-to-face and pushing back to say, you know, that this document is not going to cut it because it's not been signed by a physician or physician designee, or it doesn't say that that's that kind of wound. The nurse did put diabetes in the narrative, but there's nothing to back that up. Yes, that's conceptually in a credential, but we've had individuals who really, really struggle and aren't a good fit as a reviewer because they can't apply that to those activities. On the Oasis side, I've seen the same thing where I have a credential. Well, when did you last take that test? 2 years ago. Well, Q&As come out quarterly, and sometimes they have things in them that definitely change from what the guidance book says with its annual update. This Q&A supersedes it. So I need to make sure that folks that are doing this work are on top of that. So I would say at a minimum, once a year. That's a bare minimum. I would prefer to say twice a year minimum, but I know that operationally it can be a challenge. And to make sure that this is just working consistently because as Sherry touched on earlier, when the let me make it as an example. We'll get a question. I don't like how my outcomes are going. Oasis is still a problem. We need education for the clinicians. And I will always say that's part of it. What about your reviewers? Well, what do our reviewers have to do with it? Because if the reviewers aren't consistent in their messaging, it is incredibly frustrating to clinicians when one tells them one thing and the other one tells them something else. Or they get very frustrated with the review process and basically give up in terms of I'm going to turn this in however it is because the reviewer is going to tear it up anyway and tell me what I have to fix. And I might complain about this, but it's easy. You tell me which ones are wrong. I agree with you. Life moves on. But now we look at it and say we have staffing shortages. The pandemic did not help this. Vaccine mandates may affect this. Do I really want to keep a model where I've created a codependent relationship between my reviewers and my clinicians? Because Oasis E is going to be a great opportunity to revamp this and say, we're going to have to pay attention again because this is a new letter, not just a D3, it's a new letter. So how do we structure it so that the reviewer is helping clinicians to get smarter so they make less mistakes? So I don't have so much time and dime consumed in the review process or think every time my agency grows, I have to add more reviewers because we need to have all of this eyes on them and we know they're going to make mistakes and we have to have all of this expense. But I think very often when you're looking at how your program is running, those reviewers are a critical piece in determining how effective and efficient this is. And I'm just going to say this as a reviewer. Don't be fooled by the, if I don't look at every single thing they do, this whole thing will fall apart. And no, we've got to make sure clinicians do it right the first time. We reward their consistency and move them to periodic spot checking, because the model of I'm going to check 100% of everything every single time forever into all eternity, now with an Oasis E and all this other stuff, is extremely expensive. And if they're not on part of the solution, they can be a big part of the problem.
Excellent. Cindy, I'm going to let you end with discussing the new regulations that are upcoming once the public health emergency ends regarding OT and the start of care.
I think the simplest, and maybe I'll have the shortest answer for you, Sherry, this time. Sorry,
Okay.
just fired up today. Um, we have to remember that the final rule is talking about rules. It is not talking about waivers. Waivers are a PHE thing. Waivers that are in play are still in play. PHE continues to be extended. Those waivers may go with them. They may be disconnected from them like they opted to do with Oasis E, but waivers are waivers. What the final rule was talking about were the rules. And so the end result was, in a situation where nursing is ordered along with therapies, nursing will continue to be the one who does the admission. Again, waivers have different situations and they are still in play. The underpinning regulation remains the same. If nursing is part of the plan of care, that is the one expected to do that admission and comprehensive assessment. What changed is in a situation where nursing is not ordered. So previously, that meant that a PT could admit or a speech pathologist could admit. What's new is if OT along with, so they're ordered along with PT and or speech, so they're in there with more than one therapy, OT can do that comprehensive assessment and admit the patient. So if we think of the classic orders of PT-OT together, PT-OT, no nursing, either one can do that admission now, which brings up great opportunities for dealing with staffing challenges, availability, looking at the needs of the patient, all that good stuff. What hasn't changed is OT cannot be a qualifying service by itself for home care. So this issue of, well, OTs can admit, can OTs stand alone? They cannot stand alone to initiate care. They can, if we recertify and they're the only service still needed, they can recertify and continue on their merry way by themselves. But that service, the need for OT, does not establish a qualifying criteria. This has nothing to do with their skill level. And this is such a big issue, literally. To change that aspect would take an act of Congress. This is outside the boundaries of CMS could just make a change. Somebody over there is just belligerent. That's not what this is. This is a congressional thing to try, and we see how fast everything moves in that arena. It's been a 25-year, literally 25-year battle for OT to try to get that fixed. So they didn't get that because that's, well, way more complicated. We didn't get a change about if nursing is ordered, they have to do it. But in therapy cases without nursing, if OT is in there with PT and or speech, they can be the one to do the admit. So I can see why this was confusing, because we're thinking waiver, we're thinking PHE, and then the rule came out and it looked like it contradicted the waiver. And how come it did? Those are two separate things. Much like the supervision of the aid, we want to make sure we're following the waiver as in play, but very aware of what the rule continues to be, so that when waivers are changed or eliminated, we will go back to those rules. But going back for OT means multi-therapy case, they can do the admission. That has been made permanent.
And Cindy, one more time. Is Oasis E starting on 1/1/2023?
Yes, absolutely. Tell everybody you know, call your other agency friends, just make sure. Don't be surprised if people think that wasn't true. We got to get the word out, because prep is going to take some serious time. And we want to make sure we don't get caught at the last minute thinking, well, it's not till 2024. That is not accurate.
So the key here is, and I'm gonna cut Cindy off there, and the key here is that you keep an eye on the public health emergency that was extended in October into January 2022. I am of the mind that I do believe it will be extended for at least another 3 months. It looks like they're doing a quarterly assessment of the public health emergency. And I just can't imagine, with everything that we've been through, all of us collectively in the last couple of years, that they're going to sunset the PHE in the middle of winter time. It just does not appear that that's going to be the case. So keep an eye on that. And as long as the PHE is in effect, the public health emergency is in effect, um, then absolutely you have those waivers for the aid, you have those waivers for OT and other myriad of healthcare waivers that are still in effect as the PHE is in effect. And we will be letting you know that with our daily blasts. As we get that information, we forward it to you guys and hope to remain a great resource for you guys going forward. And please do not hesitate to contact us if you have any additional questions. And I just want to thank each and every one of you for taking the time out of your day and joining us for this Q&A. And it is our honor to serve you guys, and looking forward to it going forward. Thanks and have a great day.